which means that it has a five French cheese outer sides. Looking for the five French cheese, it's downward as a pink, which may indicate that before it is the same color of four French. So using the five French cheese, the outer side is just only for the four French. So the same thing that using the four French cheese, its outer side is also three French cheese. This is a very unique and very useful cheese, which is makes it very available to make them one size down. So let's talk about the catheter types. There are many types of cell catheters, but first of all, I would like to talk about the French size. What does mean for it? It's an indication of the thickness of the diameters. For example, if you choose the 7 French sheet, that means 7 divided pi, which is 3.14, means that it's 2.2 millimeters. So we just use for the 4 to maybe 8 French sheets. But using this formula, we can get very easily what's the thickness of these capillars. There are several types of the catheters. The most important, famous one is something like the pigtail, or maybe you can imagine about the Swan-Ganz catheters. But today, I would like to talk about the Balmer catheters, which has a very small hole on the side, which means the lateral hole are open for the contrast. And this is a very important catheters for us. So this is another pictures of the angiographic catheters, which we mainly use pigtail, intermammary artery catheters, just against right, left, just against right, March purpose catheters. This is the pictures of the Balmer angiographic catheters. As you can see, on the top of the catheters, there's a balloon, which we have to put the balloons inside the carbon dioxide. For the imaging, if we put the contrast just below, just below the balloons, there's a sidle here, and from here the contrast will come out. And using those holes, it should be contrasted very well. If we use the wedge balm of catheters, we just balloon at the very peripheral side of the peripheral artery. We can able to measure the PA wedge pressures, which mean indicates the left atrium pressures. This is the most accurate way to evaluate the pressures of the left atrium. But still, the balloon should be expanded. This is the pictures of the gases. And the top of there, we put the syringe here, and the gas will enter, the carbon dioxide will enter the sheath syringe, and then we using those syringes, we'll just push for the balloon dilate with the carbon dioxide. This is the pictures of the guide wire. The most famous guide wire is the radio focus guide wire, which is coated with hydropolymer polymer, and it looks like very sloppy, a very soft one. But in a word, in a cord, there's an inner cord, very stiff guide wire, which is very stiff, and if you use it in the coronary arteries, it may hurt the coronary artery. It may perforate it very easily. So please do not use it in those very important veins. There is many kind of much more softer guide wire. So you have to be very careful whenever you use the razor focus guide wire. The the appearance looks so soft, but the inside the wire, it has a very stiff inner core. So we should be very careful whenever we use it. radiofocus guide wire. So next point is important to understand the anatomy of the patient heart. Because we start catheters, we just see the cardiac silhouette from the X-ray. I think they almost all the patients should have a picture of the X-ray. So those entire cardiac shadow should be checked, and we should be make a plan how to advance to the each cardiac chambers. So 3D dimensional understanding of the anatomy is very important. As you can see here, I just put in illustration about the cardiac silhouette, but it is too much roughly. It doesn't make roughly. This is the wrong way to make image. But if you put this is the just taking a 3D CTs, just taking if you put on X-ray, you can able to understand how the alveoli are located are and where the pulmonary artery valve are located. But it should be not so frequently done. So when the if you were able to do the CT scan, something like this, and then you just trace or looking at this X-ray and see how the alveoli are and where the pulmonary vein are. Maybe you can try to index, imagine that where the left atrium are and how the uh, pulmonary arteries are located. And also, there are several points that we should be very careful as the most famous place is the appendage of the upper side of the radiatum, and the most important things is to understand where the outflow tract are, because the wall of the ventricles is very thin. It's very easy to get penetrate or maybe perforate of this area. We have to be very careful whenever we try to manipulate the catheters among these places. So if we put the catheters inside and then we fill with water, we will be able to measure it with using the pressure transducers. But still, we have to evaluate whether the pressure is adequate or not, because if it has a fully water, it should be uh, sharply show the pressure. But still, if there's something blocking inside the catheters, for example, if there's a air or maybe something like a space, the shape of the pleasures should show something like dull or maybe damping. So whenever we see those kind of the damping or dull, we have to check that how the catheters are. You know, if there's something air bubble inside, we have to get rid of it. Maybe we have to change the catheters to reflect the uh two pressures. Maybe circulate connections is a little bit not rigid. Be sure that it has combined very tightly. So this is a pictures of showing the normal pressures of each part. For example, the RS should be around 2 to 8 millimeter mercuries. LV should around maybe 30. PF pressure should be around 20 to 30. The mean pressure should be below 20. So the PF pressure should be around maybe 4 to 13 millimeter mercuries, which means that LA pressure is 4 to 13. And LV pressures should be around maybe on the 76 to 100. The endothelial pressures should be around maybe 10. So this is all just only the normal patterns, right? And we have to keep those normal limits among in each mind. So this is the pictures of the aortic pressure curve, which means that it will reflect the true pressures. It should be very nicely recorded. This is the pictures of the LV ventricle pressures. You can see the very nicely of where the endodiastolic pressures are. We have to be careful to evaluate the endodiastolic pressure because that's the only way to, the second way to understand what's the true numbers of the LA pressures. So the next thing is the purpose of the oxygen saturation measurement. Why we should do this? This is the sample of the ASD cases. As let look at the illustrations. The LA saturation should be around maybe near to 100 because of the pulmonary vein flow will just enter gathered inside the LA. And it because of the interatrial communication, it will just enter into the aura, which means that there should be step up. The SVC saturation 67 and the IVC saturation 73, which means that in some part of the AST shunt flow will enter to the IVC, which arose larger than IVC, SVC saturations. And those are mixed, so it should be around maybe 84. So using those numbers, we can calculate what's the QpQSR, which means the QP is for the pulmonary blood flow, and the QS is means for the body blood flow. And the final purpose to evaluate those kind of saturations is to measure to get the answer of the pulmonary vascular resistance (PVR). For planning to do the fountain operation, maybe the Glenn shot, the patient's resistance should be below that 2 to 2.5 watts. If the patient had larger than 2 to 2.5 watts, we could not proceed for the Glenn shots. We could not go for the fountain operation. We have to think about it. And also, if the resistance of the, for example, if the patient had PDA, maybe the patient had a VST, and the resistance was just around maybe 15 or 16 watts, we could not afford, we cannot perform the VST closure, we could not close the PDA. So at that time, we should do something else. Maybe we should do only things that we can do is the PA banding first, and then let them use the pulmonary artery hypertension drugs to reduce the resistance. So it's very important for us to evaluate the QpQS and PVR. So there are 3 points which we can only obtain the value of the QpQS, PVR, and the diastolic pressures. So that's why we always try to perform the diagnostic categorizations to obtain these numbers. Well, this is the pictures of the formula which showing how to calculate the QpQS or QS, QP or QS. Well, as you can see, the using the thermodilation method with the swan gas catheters, you will be able to calculate the cardiac output. But in the pediatric cases, I think the patient who receive the swan gas catheter should be very rare. But in some cases, it will work very nicely. The final things is just about the cardiac angiographic examinations. Well, what's the reason to put the angiogram? Is there are several I think purpose or to evaluate where the stenosis are, how much the bowel regurgitations are. Also, we have to evaluate these two sides of the left ventricle, sides of the right ventricles. As you can here see, the measurement of the left ventricle, there are several couple of options, but the most famous one and most how this well used method is the area length method. And also there are several types of measurement of the LV, but the most majority which should be done by the Kennedy method and the Dodge method. This is the measurement about the LV angiogram, and we usually use the modified Simpson rules. So this is the summaries of my thoughts. The diagnostic cardiac catheterization is very important and necessary for the complex congenital heart disease cases. And also, it's important to understand the anatomy of patient heart whenever we perform the cardiac catheterization. And to perform the oxygen saturation measurement is to evaluate the QpQS and PVR, pulmonary vascular resistance, and the measurement of the endodiastolic pressures of RV and elbow. Thank you for attention.
Okay, thank you, Dr. Ueda. Thank you very much for your presentation, and I do believe we can learn a lot from the first lecture about the basic hemodynamic in catheterization. And we believe a lot of our colleagues from our senior and professors want to have this discussion with you. This maybe we have Dr. Ruby, Prof. Yuliadi. I believe is already your discussion, and we have another distinctive pediatric cardiologist in Indonesia also join the discussion. Maybe doctors and professors and colleagues, if there is any questions our discussion, maybe can raise a hand or open the microphone so can ask or discuss with Dr. Ueda. Thank you. Hello? Yeah. Dr. Mina? Okay.
Yeah, thank you for excellent presentation about the characterization. But we want to know about the different uh, or measurement in your clinical practice if the patient is single ventricle. But before the intervention. So when is the indication of cardiac catheterization in baby with single ventricle before any intervention? Thank you.
Thank you for a question. I think it's a very important things because uh, if it is a very critical cases or if we want to do it very carefully, we just divide it in two. We just only perform the diagnosis catheterization to check whether the cases will have indications for further catheter interventions. For example, uh, if you are not to be sure that the QpQ is just, for example, around maybe 1.5 for AC cases, in some cases, we will just perform for only diagnostic catheterization to check the pulmonary vascular resistance. In some cases, the pulmonary vascular resistance will be above 10 or maybe 15. So once you place the devices among the defect, then suddenly the pulmonary artery pressure would jump up and the right ventricle injured cannot get controlled. So the congestive heart failure would happen soon after the LC closure. And also, if you found something, for example, if you found a very large PDAs, also there is a possibility for the patient who might have very high resistance of the pulmonary arteries. If the pulmonary artery resistance is just about maybe 10 or 15 or so, we have to abandon the PDA closure first. And then we have to put something else. And then we could further PDA closure. So be very careful to determine whether it has an indication for the interventions. So I do not mind if we do in the if we divide it too. Of course, we can do it in just simultaneously. We just do for the diagnostic catheterization course and then move on to the interventional cases. That should be okay. But I think it depends on each circumstances. So if there's a how do you say if you consider the high resistance of the pulmonary artery, I think we should divide it into just only look for the diagnostic catheterization and to be carefully a measurement or calculation, and you convince that the procedures might do something good against the child, then we should move on to the next catheter interventions. But still, if you don't have any confidence, or maybe if there's something unclear, I think we should postpone the next intervention till when we have a good evidence that the patient would have something good things from the interventions. Does it make sense for you?
Yes. Very important because we still have no guideline for uh single ventricle, especially because we have uh many cases for late presenter, Dr. Weda. Late presenter, like baby already 6 months or 8 months with single ventricle. Thank you so much.
Very much.
Hello, Prof. Widya. Oh yeah, really here. Okay. Yeah.
You want
Type.
to see Vietnam again?
Yes. Okay. I guess it Cat Lab. Yeah. Now. Yeah.
You're going to join to the
Yeah.
conference?
My. Yeah. Maybe tomorrow. Tomorrow.
Tomorrow.
Maybe tomorrow afternoon.
I just wait for.
Yeah. I have one question for you about using the oxygen test. Yeah. Sometime. Yeah, in complex congenital disease, for example, like in truncus, yeah, in atresia pulmonar, yeah. How is the application of the oxygen test in that complex congenital disease?
Oh,
Yeah. Do we need to do oxygen test in complex congenital disease? Yeah.
oh, if we whenever we plan to do the BT shunts, or maybe we just want to move on to Glenn shunts, we always do the saturation measurement to be
Yeah,
sure. Okay.
like truncus, yeah. We know that the source of the blood to the aorta on that way come from one chamber. So in that case, do we need to do oxygen test?
Uh-huh. Uh, if we have a uh, PFO, we'll just enter the catheter inside the pulmonary vein, and then we will just able to measurement the pulmonary vein width to pressure to measurement the pressure of the pulmonary arteries. Maybe it use the very small microcatheters will we be able to pass through the PDA, and then we can measurement it directly to the pulmonary pressures.
Oh. Yeah, you mean that even in very, very complex Windows, so we have to do oxygen test.
Yeah, I think so. I think you have reported many intervention cases very successfully. So I think the next thing to help to save the life of the HLHS, I think those kind of oxygen saturation measurement is should be very important and should be mandatory to 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 proceed the next proceed the next operations or maybe interventions.
Yeah, I mean, I think we do oxygen test in only in simple like in VSD, yeah, because by using the oxygen, it will change the direction of the sun to the VSD. Yes. Yeah, but in complex, because the aorta and PA come from the same ventricle, I think in my opinion, we do not do the oxygen test. We only do the angiography. Yeah, angiography.
Just about 5 years ago, there was a girl who was a 15 years old high school student. She couldn't able to attend to the school because she feels a very severe fatigue. And I couldn't understand because the patient had received VC closure at the age of 3. And during those echo measurement and the how do you say the the patient had already received the oxygen test before the VC closures. So there should be nothing about because the VC closures operation was finishing properly and there was no residual sound among the VSTs. But still the patient had a very severe fatigue and could not get able to reach to the schools. So I couldn't understand. Just watch for the echo. I found that the alveolar pressures was seems to be pretty high. So I bring back to the cath lab and then measurement the oxygen test and found the pulmonary vascular resistance PVR was 16 to 20 Woods. So the, even in the very simple congenital heart disease, the pulmonary artery hypertension might happen uh, maybe 5 years, 10 years later. Also, uh, I have two patients who had received XD occlusion with using the devices. The patient has suffered from the pulmonary artery hypertension. So those patients is now receiving PH drug. So even treating the very simple cases, we should be very careful to evaluate the those kind of resistance of the pulmonary arteries.
Yeah, thank you, Purweda. Yeah, thank you. Thank you very much.
And thank you so much. And also, I'd like to join you, and if possible, I would like to have some talks when we are visiting to the Vietnam.
Yes.
Tomorrow, Prof. Mulyadi will talk to RFAB.
Okay, Dr. Gueda, thank you very much. Thank you for Prof. Mulyadi and Dr. Winda. And I do believe there is still a lot of space for discussion. Maybe professor and doctors who still have cases or question that will be discussed. It's free. You can freely raise your hand or open the mic to have question.
How about you go to the next house? This is Peru. She goes, which I said, not capable.
You want to talk to every yes, the move?
Sardari.
Yeah. It's okay. Yeah. Um. mm, yeah. Maybe Dr. Ueda would like to explore much more deeper about the QpQS. So we can change. Dr. Ueda is preparing to change the slide.
So I would like to talk about the saturation with the congenital heart disease. So the question is, if someone asks you that if the patient's A has a saturation is just around 80, what would you do? What would you kind think about it? And who can cry a lot during the blood test? To whom we should pay special attention for it? So the objective of this talk is to find optimal saturations. So before going to forward, I would like to review shortly. What is QpQS? QP means the pulmonary blood flow. P means pulmonary, and it's mean that amount of blood flowing through the lungs per minute. QS means for the body blood flow. S means the systemic. So it means the amount of blood flowing through the body. Which means that is equal to the cardiac output. So normally, if there's no shunt, the QpQS is always 1. But if there's something shunt for, which means that if there's an excessive permanent blood flow, the QpQS should be above 1, which means that permanent blood flow is greater than body blood flow. If the QpQS is under 1, which means that pulmonary blood flow is lesser than the body blood flow. We have to be always thinking about this. QpQS is above 1 means that it's high flow. If the QpQS is lower than 1, which means that it's a low flow stage. So what is the optimal saturations? I think there is only 2 final stages of congenital heart disease. Only 2 patterns to are made for. Whenever we see if there's a patient who might have a congenital heart disease, we have to determine in which way we should go for it. There are 2 options. One is for 2 ventricle repair, such as the PDA closure, maybe the VSD repair, maybe the corrections of TGA, maybe the corrections of the tetralysis follow. But the other side is just go for the single ventricles, which means that the patient could not receive the 2 ventricle circulations, which means that the patient should be survive only with the phantom circulations. So born with the only ventricles, maybe the other side of the right or left ventricles is too small. We have to do something else. We have to go for the phantom operation, which means that the first palliation should be pulmonary artery bonding, or maybe we have to uh, introduce the BD shunts, or maybe we have to put PDA stenting to receive the amount adequate flow from the aorta. The next things we should go for is the Glenn surgeries. And the final purpose or final surgery should be fountain surgeries. But it should have step by step. We cannot go in one time. This is the pictures of the brain surgeries. The SVC will be connected directly to the permanent arteries, and the just leave it alone. So the upper extremities, the blood flow will enter the permanent arteries, and then it will just go inside to the left atrium. So after that, the blood will be mixed from the atrial blood and the venous blood, such as these pictures, as you can see, from the lower part of the extremities, which with a blue, it will enter the only single ventricle, and then from the red blood from the LA, the the colors should be mixed, so it will turn to the purple, and then it will go to the aorta. So after the Fontan surgeries, because of the artificial conduit will connected between the IVC and SVC, the total venous return will go directly to the permanent arteries. And only the red blood flow, which means that permanent vein will enter to the LA. So the LV will be received, the single ventricle will receive only the very high altitude of full rich oxygen blood flow, and it will supply for the circular systems. So I think there is only five types to know about this. What's the ideal saturation are? Biventricular circulations with the without cyanosis, and the single ventricles phantoms for before gland shunts and after gland shunts and after phantom operations. So I would like to focus about the single ventricles, such as before, after, and after phantom operations. So looking at the before gland shots, this is the most important thing because the patient will suffer easily to suffer the congestive heart failure and get very unstable. And this is the most dangerous part of the whole life. So suddenly the saturation changes would happen very easily. Maybe it may drop, maybe it may get arose. So we should be very carefully to handle it. It means that this is the most dangerous time, which means it's a very unstable phase. We have to be very careful. So I would like to show one sample of those kind of things. This is the PA with pure permanent arthrosis. As you can see, the permanent vein, permanent valve is very arthritic. So it cannot get supplied the adequate flow to the permanent arteries. So besides there is a PDA here, and because of PDA, it would supply the totally the permanent artery flow. So it means that the always purple color will enter to the left ventricle, and it will go pass through the blood flow uh, to the aorta, and via PDA it will enter the PA, and it will go the lower extremities. Something like this. Okay? But it will shed always a cyanosis will happen. So the blood going to the aorta and the permanent arteries is the same. That's the most important things. So how we could calculate the QpQS? If the saturation monitor shows the 85 percentage, the aorta saturation should be 85. Also, the saturation of the permanent artery should be 85 because both of them are just on the same blood. So using the formula of the QpQS should be 25 divided 15. It means that the QpQS is just around maybe 1.6s. But you can get roughly estimate the QpQS just only with the SpO2 monitors. And even for the same person, the QpQS might change with a very handily easily. So especially the before Glenn shunts, pulmonary blood flow tends to suddenly increase or decrease. So to be sure that we should be very carefully handling because of those suddenly changes. So what does mean for BT shunts? As the picture show that there is a uh, artificial vessels connected between the subclavian artery, right subclavian arteries, to the left femoral arteries, which means that it is similarly, it is just same as the hemodynamics are the same as the PDAs. And also, when we put the PDA stents among the PDA, you can use the same formulas. So when we found if the patient of the pure pulmonary atresia and the monitor is showing this SpO2 is 90 percentage and using the same formula of the QpQS, it will be the QpQS should be around 0.33, which means that the blood flow of the pulmonary artery is not enough. It's just lacking. So we should keep very careful. So at this point, we have to ask for the consultant to be sure what we should do next. It is too low, right? But if the saturation using the monitoring shows the 85 percentage, roughly the calculated QpQs should be around maybe 1.66, which means that it's very good and it's very acceptable. So we just keep let a look. But if the saturation showed 95 percentage, we should be very careful because roughly the calculating QpQS should be around 7, which means that the volume overload against the LV will happen soon after this. And because of the very excessive flow inside the pulmonary artery, the system circulation could not be maintained properly. So only looking at the saturation, we could find that whether the patient is stable or not. If it is just below maybe 80 percentage, it means that the patient would suffer from the desaturations just only because of the low flow of the pulmonary arteries. But if its saturations go above 90 percentage, which means that the systemic flow is very lacking. So we should keep in mind that there is something wrong among those saturations. We should move on something to correct the QpQS. So QpQS means that which is better, higher or lower, and which is worse. Of course, the high is worse because the high QpQS means that the low QS, which means that cardiac output is getting lower. It cannot be maintained properly. The lower output syndrome, LOS, for example, may happen at this time. And what is happening highly is very easily in the especially for the neonatal period or maybe the lower body size infant, maybe just younger than 1 or 2 age baby. It should be next should be get easy. So the among the whenever we place the patient who had received the BT shunts and the if the chamber systemic chamber is weak, well, we always have a easily net would happen in very high incidence. So SpO2 lasting over 90% below blend is very bad. So which means that low output syndromes will happen. Well, it's so please consult immediately whenever you see any symptom, such as the bloody stools. And this is the worst things that I think that if you found that if the stools color turn red, we have to rush for something. We have to do something to correct the large QpQS. So I would like to talk about the after glance shots because after glance shots is definitely different from the before and after. If the saturations of the monitoring shows 80%, it means that it is just only 0.7. But before the glance shots, the showing the SpO2 80 should be around maybe QpQS maybe should be around maybe 0.5. So SpO2 after the glance shots 80 is very adequate and very ideal numbers. And please remember these numbers. 80 is very important for us because it means that it's always the QpQS is 0.7, which means that soon after the glance shots, the volume overload against the single ventricle will happen to be appeared very nicely. So it means the burden of the single ventricle can get very easily reduced. So whenever we see the conjugate heart failure of the single ventricle circulations, we just move on to glance shots to reduce the burden of the single ventricles, which means that we could able to drop for 1.5 to 0.7. This is the most reason to perform the glance shots. So this SpO2 80 is very nice and just keep observations should be enough. So what about the QpQS of the single ventricles? Even the same persons, it changes greatly depending on the saturation situations. So please check the SpO2 on monitoring for the rough estimate. So what about the single ventricle cases? Okay. I think we could. So this is the last slide, I think. QpQS must be exactly what is not, because it's difficult to completely what. We have to turn it into a certain extent. Referring to our experience, QpQS around maybe 0.7 to 1.5 is within the acceptable range. This is our target. So summary, during the daily practice, always consider about the QpQS is very important. If the QpQS is around 0.7 to 1.5, the patient should be very stable. But if you found the QpQS is just about maybe 3 or 5, please do not leave the patient alone. Please contact the consultant to do to rest of this excessive flow of the QP. So in our institutions or in our countries, there is very good things to use. I would like to recommend to use the nitrogen gas because just only the small amount of the nitrogen gas, it should be very easy to control the high QpQS. Because, for example, if you use the room air 2 liters per minute and plus the nitrogen gas 1 milliliter per minute using the Y-shaped connectors, something like this. If you use these combinations, room air 2 liters and nitrogen gas 1 liters, the oxygen concentrations where we drop to 14 percentage oxygens. Yeah. So as it, for example, the Himalaya mountains will just obtain 8 percentage oxygens. For the room air, we have a 21 percentage. The altitude of the 3,000 millimeters overseas, the oxygen concentration should be around maybe 13 to 14. And that is the most lowest acceptable saturation of oxygen. So we cannot get lower than 13 to 14. So that's the reason because the human could not survive above the 3,000 overseas. So that's the most highest place that human can live safely. So that's the numbers. We just uh, get the numbers of 13 to 14. Please do not use the 8% oxygen because that means that you have bring the patient to the Himalaya mountains, right? 8% is only for the Himalaya mountains. So it should be very dangerous. So we have to be careful to control, but still, among using those kind of the nitrogen gas, it, I think those gas should be used in the commercial base because I learned that before it is used quite frequently into the tire of the racing car tires. So it should be very cheap. And in Japan, I think using the nitrogen gas, the cost of the natural gas is just 1/3 of the oxygens. So target oxygen concentration with nitrogens is just around maybe 13 to 20. Please do not reduce to less than 13. The conditions to determine that the concentrations are to keep the saturation in the higher 70s to lower 80. 75 to 83 percentage is the target. And to be sure that there is no acidosis would happen, and then you will find the reductions of the cardiac signs of hyponatremia or maybe tachycardia. And also you will be able to obtain the adequate urine output. So which patient should be receive the nitrogen gas? The heart failure with massive shunting of the pulmonary artery with extremely high flow of pulmonary arteries are the indicated. And the patient with systemic fluid supported from the pulmonary arteries via PDA, such as the HLSS, truncus atriosus, PDA, TGA, TPVD, or post-PD shunt cases. These are the very roughly data looking at the SpO2. Soon after the insertion into gas, you can see the saturation had dropped very fast. This will happen soon after maybe 5 minutes or 10 minutes or so. And also the respiratory rate, you can see the tachypnea of just around maybe 70 to 80. It will just drop to 60 to just below the 50s. So these baby's colors will turn very uh, the if the patient had a white, it will just return to pink. So you can get very easily to understand how the nitrogen gas do good things against the babies. So problem with the question with the natural gas is that is the cerebral saturation maintained? Is the oxygen supply to the whole body sufficient? Is there any problem with the natural gas itself? The answer is after the nitrogen gas is started, it will increase in oxygen supply to the whole body. It will increase in body flow in the middle cerebral arteries, which means that those effect is stronger than the increase in the oxygen concentrations. This is a very famous theoretical model, which of the HLSS mean that if the QpQS is just around one here and here, if you can see if the saturations go near to this 90 percentage, the O2 delivery will be dropped to dramatically very low at a very dangerous area. But if the saturations go to maybe 60 or maybe just 70, those the O2 delivery will go to the maximum, which means that the body will get very in a good status, as you mentioned. So, but keeping the saturation in this low, it should be very difficult, and I think we could not get feel comfortable. So during these 70 to 80 should be enough. So, but please keep in mind that never put the patient above the 90s. Please use the nitrogen gas to reduce the saturations. The next thing, the last thing says, is there any problem with the natural gas itself? The nitrogen gas is itself is naturally present in natures. And also the substance itself is very stable and does not react with anything. So there is no effect on the pregnant woman so far. So the question is, the nitrogen gas could be used in very safely. So this is the end of my slide. So I would like to mention about the importance of the diagnostic catheterizations, and I would like to mention about the QpQS to evaluate where the patient are and how the content heart failure are happening to that patient, and finally, if possible, I would like to recommend to use the nitrogen gas to to do something against if the patient have suffering from the high flow QpQS. It should be reduce the pulmonary blood flow. Thank you for attention. Thank you.
Thank you very much, Dr. Ueda. It's very unlikely that I do believe that we can have a very much discussion with this, with the interesting topic about the QpQS and how much we can evaluate patient. Maybe in the bedside using saturation oxygen, we can roughly calculate the QpQS and give a proper treatment for the patient. So maybe if doctors, professors, and seniors and colleges, if there is any more question or discussion, please state.
You want to question to Prof. Yuda?
Yeah, Dr. Anissa, please. Dr. Anissa want to have a discussion.
Okay, yeah. Thank you, Prof. Weda, for the great lecture. So, continuing Prof. Mulyadi question, how about vasoreactivity test, Prof. Weda? Can we do the vasoreactivity test in single ventricle patient? Usually for the late presenter, so we can decide whether we can proceed to either BT-SAN or other, or in case like truncus arteriosus, can we do the biventricular repair for this patient? So the question is about the vasoreactivity test in cyanotic or complex heart disease. And also, what agent do you use? Is it only oxygen or nitric oxide or nifedipine or other? Thank you, Prof. Yueda.
If I found the patient has a very high saturation, we just start the nitrogen gas, because if we start the natural gas just containing about the 15 or the 18 percentage, the saturation will drop to around maybe 85%. So after that, uh, we do not want to perform the uh, correct open heart disease in a very quick, because if even we could able to perform the open heart surgery in the neonatal period, but still the the functions of the ventricle to get very it should require many times to get fully recover. So if possible, we would like to wait maybe or 10 days, or maybe if possible 14 days, because the heart condition will get very stable at that time. That's, I think, one thing. And also, the if we put the prostaglandin to how they say, to keep the PDA wide opening, but still those prostaglandins have a side effect that it will reduce the pulmonary artery resistance. And suddenly, if the saturation would happen to show the very high uh, values, something, if you put the PDA, if you put the prostaglandin for HLHS, it's the HLHS cases should go very fast to the above the 90 percentage. So you should go. How do you say? We should put the nitrogen gas first, and then move the patient to the operation room to have to put the PDA stenting, and also simultaneously perform the PA band in the same times. And also the most difficult cases of the truncus atriosus, there are so many options. And also, it's very difficult to get survive. So it depends on each. I think the surgeon's philosophy, or maybe surgeon favorites, or even with surgeon's experience. So I could not get answer in only one answer. But still, we have to struggle to find which is the best way to get survive the patient of the truncus atriosus.
Okay, Dr. Anissa, do you have any further question or still have to discussion, Dr. Anissa?
Thank you, Dr. Ira. Prof. Yueda, one more question. How about the useful of doing the oxygen test and also proceed with vasoreactivity test in transposition of the great artery?
Mhm.
Thank you.
Thank you so much. I think we did not do the oxygen test for the TGAs only, because the only thing that we did is a little interstomach first, and then move on to the operation do for the what's scope, yeah, for the collections of TGA. In the present time, our surgeon does not feel a little discount. Is me poison. Just wanted to train the physician within the weeks. So and present time the number was to perform for the balloon, very little. There's a lot with uh the four case for each. But the that's and you sort of like experience and not all of it. Well, what I think as a few time, the only things about to do is the it's a lot of but get the way it needs is to maybe limiting it is some which really combine those calorie liberations to reduce the final radical a complete heart surgery. Others.
Actually, was better. Oh, no, voice. Okay. Maybe for the last, uh, there is a transmission disruption. Dr. Winda, maybe which part that is not still clear, Dr. Winda?
Now the voice clear enough. Previously double sound, double voice. Maybe because there are two devices.
Oh yeah, I'm sorry. Do you need a more brief explanation about the last question?
Uh no, I think maybe if Dr. Anissa have no more question, it is okay.
Okay, Dr. Anissa, I'm sorry. Uh, do you still have any further discussion, Dr. Anissa?
No one question. Thank you, Prof. Yueda and Dr. Wira.
Okay. I think that's conclude our first hybrid lecture today, and I think it's very interesting case, interesting topics, and we can have more discussion maybe outside the Zoom meeting. I will conclude this meeting for today, so we can have lunch and rest for a moment.